How many, just for my sense in polling, how many physicians in the audience? Just raise your hands. APPs? Shout out. Good, nice. Other social workers? Good, all right. So I'm going to talk about alcohol use disorder and cirrhosis. And to me, this is a new clinical entity that I think needs to be brought to the forefront of practicing clinicians. I'm not focusing just on the alcohol use disorder, which is the substance use disorder, or the associated cirrhosis, which is the medical complications of that alcohol use disorder. I'm now focusing on as a combined entity, focusing on the due pathology of these two diseases. And what I'm going to discuss over the next hour or so is the imperative that we look at this clinical entity differently, and that we make changes in the way we diagnose, engage, and treat patients with this clinical entity, AUD cirrhosis. Just a little bit about myself. I think the more important thing is I've been in hospital medicine for about 2 decades. If we talk about moral injury, burnout, I will say about 6 years ago I was done. I had enough of ED throughput, patient throughput, how can we discharge patients before noon. And I was at a point where I could no longer functionally practice from a mental health perspective in addiction in hospital medicine. And I would tell you at Mass General, we are at the forefront in terms of dealing with substance use disorders, not only the impact on hospitalized patients, but also patients in the community. And because of our substance use disorder initiative at Mass General, I was able to complete an addiction medicine fellowship in 2018. And I would tell you today, I no longer suffer from moral injury, burnout. I am 100% professionally satisfied, personally satisfied in my career. And the one thing that we all go into medicine is to help patients. And I can't tell you the opportunity to help patients with substance use disorder is more prevalent in today's society. And it gives me added benefit of not being exposed or experiencing burnout in terms of the overwhelming bureaucratic decisions we need to address in medicine. So I would tell you, because of my long career in hospital medicine, most of my focus is on patient safety and quality, and that's the lens I'm going to talk to you about today. And the same 6 pillars that we apply to all other parts of the care we provide to individuals in this country, I have the same pillars. Right? For my framework for a clinical approach to any individual alcohol use disorder is making sure that care is safe, right? We're making sure access to alcohol use care that saves and improves lives, making sure that care is effective. And that's using effective evidence-based pharmacotherapy to impact mortality and morbidity in patients who have alcohol use disorders. Making sure that care is patient-centered. And I would tell you what I mean by patient-centered is making sure that there's a trauma-informed approach. This is outside the scope of this talk, but if you understood the amount of adverse childhood experiences that individuals with substance use disorders have, you would understand that the trauma that individuals with substance use disorder, specifically alcohol use disorder, impacts their decision not only to engage in alcohol use, but also develop the negative consequences of alcohol use disorder. And care that is also timely. And that means we should be screening or discussing with every patient at every clinical encounter their alcohol use and whether they meet criteria for unhealthy alcohol use or along that spectrum, alcohol use disorder. And then care that's efficient, and that means having access to standardized care for alcohol use disorder or unhealthy alcohol use, and then care that's equitable, making sure that in every patient who has an alcohol use disorder, in every clinical encounter, every setting, they're getting the care they need to address their alcohol use disorder. Slide I have in every presentation talking about words matter, right? On the left is the things that we've historically used in terms of describing individuals with substance use disorders. On the right, the stigmatizing language that makes our clients or patients feel less than whole, judged, stigmatized. And so there's an evolution over the last 5 years to really get rid of that type of language and start talking about non-stigmatizing language. Instead of saying describing someone as a substance abuser, we're saying a person with a substance use disorder, and the list goes down of all the words that we have eliminated from our lexicon when dealing with individuals with a substance use disorder. And this specific talk, I want to make sure we understand I'm talking about alcohol-associated liver disease. I'll say ALD, alcohol-associated cirrhosis, AC, and alcohol-associated hepatitis. My objectives for the next 40 minutes or so is briefly recognize the neurobiology, the epidemiology, and the diagnosis of alcohol use disorders. Review current trends of alcohol-related morbidity and mortality. And I'm really going to focus on the tremendous amount of impacts of alcohol use disorder during the pandemic. Understand the pathology, the due pathology of alcohol use disorder and alcohol-associated advanced liver disease, this clinical entity I'm calling AUD cirrhosis. And then really spend a lot of time, because clinical studies have shown that providers are really unsure about how to use pharmacotherapy for alcohol use disorder. I'm going to spend some time talking about the benefits of pharmacotherapy in patients with AUD cirrhosis. I might go through those slides. I put them in there for you so you can have as reference, but there's a lot of information about effective pharmacotherapy. And then I'm going to talk about a pharmacotherapeutic approach to the person with an alcohol use disorder and how I follow this ADEPT model to really provide the most efficient, highest quality, effective care for patients with alcohol use disorder. This is a study I read when I first became a fellow. It's Dr. Grant, who has worked with the NIAA and has led the largest epidemiologic study on alcohol and alcohol-related complications in this country. And this is a quote from her: "Alcohol use disorder, defined by DSM-5 criteria, is a highly prevalent, highly comorbid, disabling disorder that often goes untreated in the United States." And I just put this phrase here, this quote here, because this is a phrase in 2015. And I can tell you, when the phrase was made in 2015, looking at today, not much has changed in how we treat individuals with alcohol use disorder. It's a complex, multifactorial, chronic brain disorder. And I would tell you, in my early days as a hospitalist, I didn't quite understand that, and I would struggle with treating patients with not only alcohol use disorders, but substance use disorders. But my framework and my philosophy of practice has changed now that I understand that substance use disorders, in particular alcohol use disorders, are a chronic brain disorder and should be treated like any other chronic disorder. The more important features of alcohol use disorder is the early onset, and it's characterized by a compulsive use despite the harmful consequences of this disorder, and a return to unhealthy behavior is comparable to other chronic disease. I cite a familiar study up there in the corner where the return to alcohol use and comparing to other individuals, diabetes and hypertension, and those individuals who don't take their medications, the rates are exactly the same. And so we should be treating alcohol use disorder just like any other chronic disease, hypertension, diabetes, with the expectations that our patients might be quote unquote compliant or adherent, but we need to be there in the scenario and the situation to address why they're having issues dealing with their alcohol use disorder. And just like other chronic diseases, it's a small minority who generate a significant amount of the morbidity and mortality, healthcare utilization, and healthcare costs in terms of alcohol use disorder in this country. Certain demographics, and I'll try to highlight that throughout this talk: older adults, younger patients, women, are becoming increasingly more susceptible to the complications of alcohol use disorder. And individuals with alcohol use disorder and alcohol-associated liver disease require multidisciplinary, longitudinal, primary mental, behavioral, and psychosocial care. You can't try to address the severity of alcohol use disorder with one modality alone. It has to be a team-based approach to effectively treat any individual who's seeking treatment for their alcohol use disorder. And this will be a common theme that I will say over and over again. Maybe you've heard it, maybe you've not. But pharmacotherapy for alcohol use disorder, if the patient is engaged, if the client is engaged, is an effective treatment modality. Unfortunately, it's significantly underutilized in this country. So let's briefly talk about my first objective: recognize the neurobiology, the epidemiology, and actually diagnosing the alcohol use disorder. Right? The terminology has changed over the last several years. When we talk about unhealthy alcohol use in this country, we're talking about a spectrum of alcohol-related behaviors. Any alcohol use that increases the risk or likelihood of health consequences is called hazardous use. And that's usually based on a consumption threshold. You drink more than 4 drinks in a setting. For a woman, you're classified as binge drinking. More than 5 drinks in a setting is classified as binge drinking in a man. Along that spectrum of unhealthy alcohol use is alcohol use that has already led to health consequences. It's called harmful use. And so now the individual is drinking heavily or drinking more than he or she should, and now starting to develop harmful consequences of their drinking. And then on the end of that spectrum, harmful alcohol use that leads to negative consequences that meet DSM-5 criteria is what we call an alcohol use disorder. It's important that we understand the spectrum of unhealthy alcohol use, and really, as we go through this talk, you'll understand I'm at the other end, the far end of the spectrum. I'm talking about individuals who are suffering from an alcohol use disorder. Just definitions of binge drinking, heavy episodic drinking, heavy alcohol use, high intensity drinking. These are things that an addiction medicine physician spends a lot of time going over and finds joy, but not expected for you to understand. But this is terminology when we talk about research and clinical approach to alcohol use disorder or unhealthy alcohol use. These are the terms that are starting to be frequently used. And they're important. In 2021, past month binge drinking impacted close to 23% of Americans in this country. And when we talk about young adults, close to 30% experience past month binge drinking. When we look at the year 2021, past month heavy alcohol use impacted close to 6% of adults in this country and close to 8% of young adults. And when we're talking about monitoring our young adults, those in college or not, 12% of those individuals report high-intensity drinking over the past month. This is something that I really found quite educational when I went into addiction medicine. Alcohol use disorders, and we're not even talking about methamphetamines or cocaine or opioids or cannabis. Alcohol use disorders are the most prevalent use disorders in this country. When we talk about the scale, and we look at the time frame from 2017 to 2021, and we're looking at the NESTUS, which is the National Survey of Drug Use and Health, an annual survey that looks at a population-based approach to how drug use is impacting adults in this country and adolescents. You can tell from 2017, 2018, 2019, those who had an alcohol use disorder met DSM-4 criteria, hovered around 14 million. Something happened in 2021. One, the pandemic, and so the normal survey methodology had been disrupted. And two, NESTUS actually went from DSM-4 to DSM-5 criteria to diagnose an alcohol use disorder. And you can tell in 2020, what was there hovering around 14 million adults with alcohol use disorder now hovers over 20, to the point where in 2021, close to 29 adults in this country met DSM-5 criteria for an alcohol use disorder. That's about 11% of the adult population in this country. And so this is a disease that's highly prevalent and highly comorbid, and we have to change how we approach these individuals to make sure they're receiving the most effective treatment and most timely treatment. When we look at that in terms of the breakdown, this is the first time NESTUS has done this, breaking down a number of individuals in this country who have an alcohol use disorder, but also breaking it down by severity. Majority of individuals, close to 61%, met criteria for mild alcohol use disorder, but close to 40% met DSM-5 criteria for moderate to severe alcohol use disorder. That means per FDA regulations or rules, those 40% of individuals should be having discussions with their providers about pharmacotherapy for their alcohol use disorder. Unfortunately, when we look at individuals who actually receive medications for an alcohol use disorder, it was less than 1% in 2021. Less than 1%. Right. Close to 12 million individuals met criteria to receive pharmacotherapy, and I just want to tell you, less than 1% did. I've come to realize and understand and approach alcohol use disorders as primarily a neurodevelopmental disorder. Right? When we think about the maturing, developing brain. That happens over a period of age 12 to 25. Individuals at that age who are consuming alcohol are highly susceptible to dysregulations, misdevelopmental issues when it comes to brain maturation. And in 2021, and I'll highlight and talk about this again, there's a gender gap between male and females in terms of alcohol use disorder in this country. In 2021, for the first time, when we looked at adolescents, female adolescents had a higher rate of alcohol use disorder. We're reversing that gender gap that has been characteristic of alcohol use disorders between men and females for decades. And this is, again, highlighting a population demographic that is becoming increasingly susceptible to the negative long-term impacts of alcohol use disorder. Adolescents who drink before the age of 15 are 15 times more likely to develop alcohol problems as an adult. 15 times more likely. Nearly 50% of individuals who start drinking before, who demonstrate alcohol use disorder over their lifetime, 50% of those have that dependence evidence before age 21, and 67% have that dependence evident before age 25. Again, highlighting from my perspective, alcohol use disorder is primarily a neurodevelopmental disorder. We have to talk about alcohol use, unhealthy alcohol use with our adolescents and young adults before they start developing long-term impacts of their alcohol use. I find this interesting, again, to highlight, emphasize that alcohol use disorder is a neurodevelopmental disorder. You'll see throughout my talk that I do reference population studies from other countries, specifically those that have a single healthcare system, a very accessible way to learn about their populations in terms of substance use disorders or other chronic health conditions. Sweden has mandatory conscription or mandatory military service of all their young adult males. And this particular study looked at about 43,000 of these young adults, 1969, 1970, age 18, 19, and then followed them for 38 years. 38 years. No other study has done this kind of longitudinal follow-up. And all they did was at baseline measured how much drinking these young men had. And what they found was that 6.1% of these individuals over the course of this 38 years was diagnosed with alcohol use disorder. Less than 1% actually developed alcohol-associated liver disease with a very, very high mortality approaching nearly 55%. But what was interesting is the dichotomy, a binary dichotomy between how much those individuals at baseline didn't measure their drinking anytime during the 38 years of follow-up, just at baseline. And those who drank greater than 60 grams per day had close to a 4 times likelihood of developing alcohol-associated liver disease. 4 times. Those who drank below that threshold of 30 grams per day, and you can tell by, can I do this? Here's binary 30 grams per day, and you can see where the difference is between if you're drinking above 30 grams per day, less than 30 grams per day, the development of alcohol-associated liver disease over the course of this study. Even 2 standard drinks per day was associated with an incidence of alcohol-associated liver disease about 3%. Which really reminds me, and I hope is a lesson that I'm able to impart. Alcohol use disorder is a young person's disease. It often takes 10 to 15 years before individuals seek treatment, which gives the false impression that this is an older adult disease. It's not. As I said before, alcohol use disorder is primarily a neurodevelopmental disorder that impacts our young adult at a rate that is unappreciated, but is becoming more and more unknown. When we talk about alcohol use disorders across a lifetime, close to 69 million American adults in this country across a lifetime will have an alcohol use disorder. About 10 million of those will have a severe alcohol use disorder. When we look at terms of past year or 12-month alcohol use disorder in terms of DSM-5, close to 14% of Americans in this country have a past year alcohol use disorder, with close to 1.1 million of those having a severe alcohol use disorder. More than 1 in 5 Native Americans will have a severe alcohol use disorder during their lifetime. When you look at the numbers in terms of alcohol impact in Native American communities, it is not only astounding, it's criminal. And when you think about your lifetime as a practicing clinician, 1 in 6 young adults will have a severe alcohol use disorder during their lifetime. 1 in 6 young adults that will come before you will have the likelihood of having a severe alcohol use disorder during their lifetime. And so we need to be prepared to have these hard conversations with our patients or clients who are at risk for unhealthy alcohol use and are at risk for the negative long-term impacts of alcohol use disorder. When we talk about actually diagnosing a DSM-5 diagnosis of alcohol use disorder, right? There's 11 criteria. I'm not going to go through them all, but the first criteria is really talking about impaired control. You can't control your alcohol use. There's no moral failing. There's no, you're a weak individual. It's a chronic brain disease, and because you have this chronic brain disease, you have an inability to control your alcohol use without effective treatment. The next set of criteria talks about your inability to meet your social obligations. You're unable to work, you're unable to do the things that make you a successful, normal individual. And then the next 2 domains talk about risky use, and really talking about alcohol is impacting you to the point where you can't make correct judgments based on the situation or scenario that you find yourself. I like to think about these as the 5 C's and the 3 R's of addiction. Anytime I'm talking to a patient, I'm thinking about these 5 C's and these 3 R's. But I don't talk to a patient and conclude what I want in terms of recommendations from their care unless I do a DSM-5 criteria assessment. The audit C, the audit other tools, if you use the audit C, a score greater than 8 will give you a 95% sensitivity that that individual has a dependence or a severe alcohol use disorder. So there are tools that we can use depending on the brevity that will allow us to understand what's going on with our patients in terms of alcohol use disorder. But the more prevalent, the gold standard is the DSM-5 criteria. Talk briefly about the current trends of alcohol-related morbidity and mortality. I call it a decade of reckoning. Over the past decade, past year high-risk alcohol use increased close to 30% and impacted women, blacks, older adults more than any other demographics. Past year DSM-5 alcohol use disorders increased close to 50% over the last decade. Again, impacting women, blacks, and older adults. Lifetime DSM-5 alcohol use disorders have increased 44% over the past decade. And it's now impacting females more than males in terms of outcomes. We're talking about alcohol-associated hospital discharges, alcohol-associated hepatitis discharges, deaths and mortality. The impact on women has become increasingly more over the past decade. 5% of all deaths in this country are associated with excessive alcohol use, 5%. And predictive modeling says if we can increase treatment of alcohol use disorder to at least 40%, we will reduce alcohol attributable mortality by 13% in this country. We've got to start treating these patients. Alcohol-related ED visits and AH admissions increased during the pandemic. When we look at the Dawn survey of network monitoring of EDs, ED visits for alcohol-related issues was the most prevalent in terms of substance use-related emergency room visits, nearly 3 times that of any opioid-related visits. When we look at individual healthcare systems, including mine, during the early phase of the pandemic, alcohol-associated hepatitis admissions increased by 50%, increasing by 2/3 or 67% as the pandemic progressed. And more important, in terms of really highlighting how the advanced alcohol liver disease in terms of alcohol-associated hepatitis, alcohol-associated cirrhosis. The only thing to actually effectively treat and cure those is liver transplant. And so in terms of healthcare utilization, with the only one effective modality to treat individuals who develop consequences of the alcohol use disorder in terms of alcohol-associated cirrhosis is a liver transplant, which is a scarce resource. But during the pandemic, forecasts for how many patients would be waitlisted or actually receive liver transplants for alcohol-associated hepatitis exceeded forecasts. New waiting registrations increased forecasts by 60%. Liver transplants for alcohol-associated hepatitis exceeded forecasts by 62%. And if you look at this, oh, where's my little, here we go. This is monthly sales of alcohol use prior to the pandemic. This explosion is why we're seeing so much more comorbidity and mortality from alcohol use disorder. There's a definite temporal association and positive correlation between increase in alcohol use and alcohol-associated liver transplants during the pandemic. And there's been no change in terms of increase in wait lists or actual liver transplanted for alcohol-associated cirrhosis or any non-alcohol liver disease indication. This is all being driven by alcohol-associated hepatitis, which has increased significantly during the pandemic as a result of more individuals drinking alcohol. Alcohol-associated liver transplant increased close to 270% during the pandemic. Again, here's the baseline. Here's when states started having stay-at-home orders, and you can see the explosion, not only for liver transplants and then candidates for alcohol-associated liver disease. Transplant wait lists increased 325%, which equated to 13 more liver transplants for alcohol-associated hepatitis during the pandemic. And these individuals are young. What I see at Mass General is individuals in their late 20s, early 30s, who are presenting with alcohol-associated hepatitis, being transferred to our institution for liver transplant evaluations. And they are around the same median age of 41. This is a very young person's disease. And again, no difference between pre-pandemic and pandemic cohorts. The only driver of this indication for liver transplantation is the increase in alcohol that has been prevalent during the pandemic. Alcohol-related deaths increased 26% during the pandemic. When we look at kind of the baseline, year over year, the increase is about 2%, and then the pandemic showed a significant increase, close to 30%. And the alcohol mortality increased for all age groups, but specifically for age 35 to 44, age 24 to 34. Fortunately, no gender difference, but I don't think that's something to celebrate. Alcohol-associated liver disease increased by 22%. And then what's so telling about the impact of the pandemic and how it had such wide-ranging effects on our mental health is mental health-related behavioral health deaths increased 35% during the pandemic. This outpaced all other cause mortality, which was at 17%. So during this part of the pandemic, alcohol use disorder, alcohol-associated liver disease was killing Americans more frequently than any other cause. And then fentanyl and alcohol-associated overdose deaths increased by 60%. Briefly talk about understanding the due pathology of alcohol use disorder and alcohol-associated liver disease. I'm dubbing this clinical entity AUD cirrhosis. Right? Here's just a diagram of alcohol-associated liver disease. It's a clinical pathological disorder, right? We don't understand the histopathological manifestations because it's often asymptomatic. When we see our patients with alcohol-associated liver disease, we're finding out by ultrasound or evaluation of abnormal LLFTs that we find that they actually have fatty liver. If you continue to drink alcohol heavily, 20 to 40% of those individuals, 80 to 90% of those individuals, understanding all those dynamics and components, including a history of trauma, including a history of psychiatric disorder, it would be challenging to address alcohol use disorder in this patient population. And then healthcare encounters, I just want to really emphasize this. Healthcare encounters are an opportunity for each and every one of us to discuss with our patients or clients the negative impact of unhealthy alcohol use. AUD cirrhosis is a major healthcare issue in this country. Hospitalizations for alcohol-associated cirrhosis has significantly increased over the past 20 years. You can tell here by hospitalizations that have gone up over the last several years. Individuals are older in terms of hospitalizations for alcohol-associated cirrhosis, and all that means is that our care at a minimum has gotten a little bit better. But patients are sicker. When we look at the Charlson Comorbidity Index, that has increased to 78% of individuals who are admitted to a hospital with a diagnosis of alcohol-associated cirrhosis. Hospital costs have increased 2.1-fold. There's a study that showed when we look at hospitalization costs for all substance use, nothing compares to alcohol. It's about $8 billion. Opioids is about $1 billion. This is a disease that dominates our healthcare utilization. And even though mortality significantly decreased from 12.8% to about 5%, Black patients are still more likely to die from alcohol-associated cirrhosis. Individuals who are sicker are more likely to die. Over the past decade, alcohol-associated disease-related transplants have increased by 120% and 26% in adults. You can see all the indications for liver transplants by diagnosis. And if this doesn't stand out, which is alcohol-associated liver disease, compared to everything else, I have misled you in trying to make you understand that the importance of addressing this public health crisis. In 2021, ALD was responsible for 40% of all transplants. In 2011, it was the fourth leading indication. In 2021, it was the first leading indication. In 2023, liver transplants continue to increase at record levels. As of September of this year, there was 811 more transplants, liver transplants, than this time last year. And I would tell you, it's most likely being driven by early liver transplantation for alcohol-associated hepatitis. Let's talk about the benefits of pharmacotherapy in patients with AUD cirrhosis. In terms of FDA-approved medications for moderate to severe alcohol use disorder, we have disulfiram. Does anyone prescribe that? Who said yeah? Somebody said yeah? Wow, lone voice. Acamprosate, naltrexone, and standard injectable naltrexone. Those are the FDA-approved medications that have significant clinical efficacy and benefits for treating individuals with moderate to severe alcohol use disorder. Most clinical trials of medication efficacy study individuals with DSM-5 alcohol dependence. There's some correlation with DSM-5, but most of our studies are old studies with criteria that we no longer use. There are not a lot of guidelines. The American Psychiatric Association, their 2018 guidelines, recommend first-line therapy with acamprosate or naltrexone, and they suggest, not recommend, they suggest gabapentin or topiramate if initial treatment with those two agents are ineffective or intolerant, or the patient prefers to try those two medications. And I want to highlight this. There's no clinical trials that studied AUD pharmacotherapy in hospitalized patients. That's just my hospital medicine background talking. And there's limited clinical trials have studied patients who actually have AUD cirrhosis. Having evidence of hepatic impairment is an inclusion criteria for the large number of trials we've done over the decades in terms of the effectiveness of alcohol use disorder in pharmacotherapy. So what I'm telling you today has not been clinically studied. It's not been clinically studied in trials, but it is clinically beneficial for our patients. Briefly, let's talk about the different categories of AUD, so try to demystify. The one thing about being in addiction medicine, like other specialties, I only have a handful of drugs I need to learn, and so I know them well. When we talk about the different categories, we're talking about mu opioid receptor antagonist, that's naltrexone. We're talking about anticonvulsants, gabapentin, topiramate. Disulfiram has no impact on the CS level. It's just an aversive agent that if you take that medication and then consume alcohol, you have a reaction that's categorized by flushing, tachycardia, nausea, vomiting. You feel like I shouldn't be drinking. And so the hope is that that aversive component of it will stop you from drinking. If I'm thinking this is a chronic medical disease, disulfiram is not medication that I'm going to prescribe ever. When we talk about glutamate receptor antagonists, we're talking about acamprosate, topiramate, and then GABA agonists, baclofen, gabapentin, and topiramate. I'm not going to go through this. This took hours for me to comprise, but this is a breakdown in terms of every single medication that you could possibly want to use for alcohol use disorder. It includes FDA-approved medication. It includes off-label medications. I've gone through many studies to get you numbers needed to treat. I've gone through when you should use it, when you shouldn't use it. So please feel free to copy that, laminate it, and put it in your pocket. When I try to think about what is the right medication for us to use for our patients with alcohol use disorder, moderate to severe, this is a nice network meta-analysis recently last year, looking at the comparative efficacy and safety for alcohol use disorder. I want to go through this because when I go through this slide, you're probably going to say, why would I prescribe any of these medications? There's nothing that conclusively say in any of the trials that have been done over the decades that these medications have more than a small to moderate benefit in terms of alcohol consumption markers or outcomes, and we don't know if they really work. But I'm going to go through this, and then I'm going to tell you why I think we should be using these medications. Right? So 5 decades of research, very extensive, comprehensive meta-analysis. Over 156 trials, 27,000 participants. Again, some of the things you'll see in most of clinical trials, younger adults, mostly white, mostly male. Most of these are 98% of outpatient settings. And so because in an outpatient setting, it's not capturing the population that I've been talking about up to this point, individuals who carry this diagnosis of AUD cirrhosis. Most of these trials, 88% looked at naltrexone, acamprosate, baclofen, gabapentin, naltrexone, but 64% of them just focus on naltrexone and acamprosate. The most of our clinical trial data is focusing and has research on naltrexone and acamprosate. Most of these clinical trials have concurrent psychotherapy. It's not just medication. That's a theme that I want to impart with you. Pharmacotherapy alone might not be the most effective intervention for our patients with AUD cirrhosis. It usually needs to be combined with some sort of psychotherapy. Most of these trials are just short duration. We don't know what happens 6 months, 12 months, 5 years if someone's been on these medications. Few studies actually had individuals with co-occurring mental disorders. I don't know of anybody, but the patients I see in the hospital with alcohol use disorder, moderate to severe, all have concurrent severe psychiatric disorders. They don't go, they're not happening in isolation. And there's a high attrition rate. It's hard to get these medications, patients in these clinical trials to actually take the medication over the duration, even if it's only a 3-month trial. Most of these studies have high attrition rates, which impacts the actual clinical impact or efficacy of these medications. And it's a high risk of bias. Right? These are not very well-designed trials that have standardization across many treatment pathways that we can use and say, this is what I'm going to do for my patient because it's been a standardized approach that has been studied across many, many clinical trials. And the heterogeneity and quality it's low to minimal. When we kind of look at whether these medications impact abstinence, really lead to our patients or clients not drinking or reduce heavy alcohol use, this meta-analysis, again, looking at 5 decades of research, highlight that disulfiram, baclofen, acamprosate, oral naltrexone had the best evidence for improved abstinence and heavy drinking rates. I don't know how to believe that. I would tell you disulfiram is a favorable medication when you think about the population that has been studied. It's mostly done in open label trials with the individual knowing they're taking disulfiram, highly motivated. We're talking police officers, pilots. And so it's highly imperative that they abstain from drinking. And so those type of studies have driven the positive effects we see from disulfiram. In clinical practice, I will say when we're talking about moderate to severe alcohol use disorder, it's not an effective medication. When we talk about the other medications, baclofen, acamprosate, oral naltrexone, those are the ones we expect to have clinical efficacy. I would tell you I don't prescribe baclofen, and I'll go through that in a little bit. I'm a big proponent of extended release naltrexone. It has favorable pharmacokinetic profile. You get the injection 380 milligrams intramuscularly in the buttock, left or right. And within hours, you see a therapeutic increase in the concentration of naltrexone. And then you see a second peak 2 to 3 days later. And then that peak starts to decline at day 14. But over the course of 28 to 38 days, you're going to have extended release naltrexone at a concentration that's therapeutic and hopefully effective. I have some issues with oral naltrexone. It has a long half-life, but the therapeutic half-life is about 8 hours. And so what you see is you take it in the morning, it peaks 8 hours later, and then you have these dips and peaks, which doesn't provide that consistent therapeutic benefit that extended release naltrexone does. Unfortunately, there's 3 studies in this network meta-analysis, and so the number of trials looking at extended release naltrexone is too small, it's too limited. Gabapentin did not demonstrate a significant effect for heavy drinking. That's not what the clinical trials have shown, and I'll go through that a little bit shortly. And topiramate may have a benefit for abstinence and heavy drinking. Again, small number of studies, small CI, but this study showed it was not significantly better than oral naltrexone or acamprosate, and it was poorly tolerated because of its side effects, in terms of CNS side effects. Let me talk about some of these medications briefly. Topiramate, there's not a lot of new trials of pharmacotherapy for AUD, but Dr. Kranzler is a heavy proponent of topiramate because his earlier work showed that there was a single nucleotide polymorphism that might moderate the effect of topiramate in terms of alcohol use disorder. His last trial showed that did not exist, but what it did show was that topiramate might be, we should start thinking of topiramate as probably a first-line agent. It controls cravings, it reduces drinking, it engages individuals in abstinence, maybe more effectively when you look at its impact than naltrexone or acamprosate. And the typical dose that we thought, 150 milligrams twice a day, this effect was achieved with 100 milligrams BID. So less dose than historically thought of, so lower dose, less CNS side effects. And what's more important is that when we kind of look in terms of medication effect, at 75 milligrams a day, at week 3, we started seeing a difference in terms of clinical efficacy of topiramate. So we don't really have to get to that dose of 100 milligrams twice a day. We start seeing that clinical benefit much, much earlier. And then when we talk about GGG concentration, short inventory scores, which is a tool used to measure the negative impact of drinking, topiramate favorably impacts both those measures. Recent meta-analysis really that shows some moderating effects of topiramate. When we talk about controlling for that attrition rate, getting our patients engaged on topiramate so they're actually taking it, it doubles the impact and efficacy in terms of heavy drinking days. It goes from 0.605 to from a 0.364 to a 0.6. When we talk about that kind of G-score, 0.6, we're talking about a moderate impact in terms of clinical benefits. None of the medications I've talked about, acamprosate or oral naltrexone, have demonstrated that in clinical trials. Again, when we're talking about patients taking the medication and not being non-compliant or non-adherent, it also decreases more significantly than naltrexone or acamprosate in terms of cravings. And if you're taking this medication for more than 12 weeks, abstinence is significantly more. Gabapentin is something I know a lot of us use. Two meta-analysis, 2019, 2020, no impact on abstinence. There's a signal or clinical efficacy for actually decreasing heavy alcohol use, but other than that, there's no impact of gabapentin on any other significant alcohol measure. Anybody prescribe baclofen for alcohol use disorder? Thank you. It's increasingly used because it doesn't impact, there's no impact in terms of individuals with alcohol-associated liver disease. And so it's not hepatically metabolized. And so there's some thought that because it impacts the GABA receptor, not the same subunit, but GABA B, that it has been demonstrated to have some impact in individuals with alcohol-associated liver disease. I would tell you a recent Cochrane review, 2023, involving about 1,900 adults, had no observed difference between baclofen and placebo. It's just like taking a placebo pill, but it's associated with a lot of negative side effects. And this agreed with their earlier Cochrane review that baclofen should not be used for individuals who have moderate to severe alcohol use disorder. Again, I like these population studies from other countries. In France, baclofen is actually approved for alcohol use disorder. And so they looked at their population study, their registry of about 118,000 patients, and where close to 48,000 of those were treated with baclofen. And when you look at severe alcohol use disorder, a fair number of those were treated with baclofen. But compared to any other medication, any dose of baclofen, and there's low, medium, moderate dose, they were associated with a 13% higher all-cause hospitalization, 31% higher all-cause mortality. Even if you're using lower dose, less than 30 milligrams a day, there was a 9% increase in hospitalization. Higher doses of 180 milligrams per day, 40% increase in hospitalization, 127% increase in mortality. And even when you're looking at any dose of baclofen treating individuals with severe alcohol use disorders, those parameters in terms of all-cause hospitalization, mortality, at all different doses would negatively impact when these individuals are treated with baclofen. And so I would conclusively say again, don't use baclofen. Acamprosate, it's FDA approved, it's been used for a long time, but I would tell you the largest clinical trial in this country, the combined trial in 2016, showed no impact of acamprosate on any drinking outcome whatsoever. And so how do we use that information when it's an FDA approved medication? I'll tell you, I don't use acamprosate for anyone who has moderate to severe alcohol use disorder. It might be effective with mild alcohol use disorder. I'm not convinced. I don't see those patients in the hospital. I only see moderate to severe alcohol use disorder. And I can tell you, unless the patient tells me acamprosate works, that's the only reason I'm going to prescribe acamprosate. And I would tell you some of it is probably from the pharmacokinetics. It's poorly bioavailable. 11% of it is bioavailable. It has a short therapeutic half-life of 6 hours. You've got to take it 3 times a day, 2 big pills. And when we're talking about treating something like alcohol use disorder as a chronic disease, that pill burden, I think, is detrimental to what we're trying to accomplish. Injectable naltrexone is my first line, second line, third line intervention for anyone with a moderate to severe alcohol use disorder. I've told you about the favorable pharmacokinetics. It's been shown to decrease heavy alcohol use. A recent meta-analysis confirmed that. And more importantly, again, the message is clear. When patients are on these medications for more than 3 months or long-term, the clinical benefits are much more. Another population study, this time in Sweden, when we talk about combination therapy with naltrexone and acamprosate. And this particular cohort of about 130,000 individuals who had an index alcohol use disorder then were followed longitudinally for up to a number of years if they were prescribed MOUD. Those who were prescribed naltrexone had significantly better outcomes. Those who were prescribed a combination of naltrexone and acamprosate had higher beneficial outcomes. And then, again, the same message, longer duration was associated with less more patient-related outcomes in terms of AUD-related hospitalizations. And I find this, again, the same study. What's very interesting is when you look at all these medications, right? Naltrexone, 11% less AUD-related hospitalizations. The combination of naltrexone and disulfiram, greater impact. And then acamprosate was associated with 11% increase in hospitalizations. Again, contributing to that unclear, uncertain benefit of acamprosate. Just wanted to highlight again what I've said before. There's no studies that have really looked at any of these medications in terms of individuals with alcohol-associated liver disease. I will tell you, alcohol AUD pharmacotherapy is effective for AUD cirrhosis, but again, underutilized. There's emergent population level outcome data in terms of AUD cirrhosis. It's very important that we address this population. Those who continue to drink, continue to participate in unhealthy alcohol use, who have an AUD cirrhosis diagnosis, have a 13% increased risk of dying, 18% increased risk in developing the incident, that first episode of decompensation, and a 72% lower likelihood because of disparities in equities and way we allot transportation resources in the country, but has 72% degree lower likelihood being a candidate for a liver transplant. And then again, highlighting the gender differences that heavy alcohol use in a woman who already has a diagnosis of AUD cirrhosis, 12.44 times likely to die compared to men who are at 3.8 risk of dying. When we look at kind of population studies across insured patients, looking at this particular study, 31 plus million patients, 27 US healthcare groups, the rate of prescription for individuals with a diagnosis of AUD cirrhosis is much lower than the prescription rate for individuals who just have the diagnosis of AUD. The rates are still low, 1.747 with acamprosate, 1.79 with naltrexone, but 37 to 65% less likely to be treated if you have the diagnosis of AUD cirrhosis. Another population study of insured patients, those who had a clinic visit for alcohol use disorder or FDA-approved medication within 1 year of an index AUD cirrhosis diagnosis, 10% of those patients had an inpatient visit, whether face-to-face mental health or substance use visit. Only 0.8% received an FDA-approved medication within 1 year of that index diagnosis of AUD cirrhosis. And women were 11% less likely to receive that medication. But those who did receive, who had a visit, had 11% decrease in the risk of decompensation. When they actually was prescribed medications, MAUD, there was a 35% decrease in the development of incident hepatic decompensation in 1 year. 35%. Just prescribing medications that we know are effective. What is the impact of AUD treatment on clinical outcomes in AUD patients, right? In this older age VA population, 14% of the individuals had AUD cirrhosis, 83% received psychotherapy, 3% received MAUD, FDA approved, and 9% received both. Those who received psychotherapy, whether medications or psychotherapy, there was a 37% decrease in incident decompensation, 21% decrease in 180-day all-cause mortality, 13% decrease in long-term all-cause mortality. Unfortunately, there are disparities that exist. White patients were more likely to receive medications. Black patients more likely to receive behavioral treatment. Why is that important? One person died who received pharmacotherapy, and when you look at the numbers, pharmacotherapy was associated with 79% fewer deaths compared to behavioral treatment. The message is we should be offering all our patients, no matter race or ethnicity, FDA-approved medications for alcohol use disorder. Another cohort looking at VA patients. These are individuals who have a diagnosis of AUD cirrhosis and actually heavily drinking. And those who were prescribed naltrexone or acamprosate in the first year after an AUD cirrhosis diagnosis had a 20% decrease in mortality. Again, this association with these improved clinical benefits when you look at longer durations. Those who had a longer duration of treatment had a 27% decrease in mortality. Mass General Alcohol Liver Center has done tremendous work looking at patients and partner is the biobank who actually have alcohol use disorder, AUD cirrhosis. And what they found is when we talk about the development of ALD incidence, any pharmacotherapy reduced that incidence by 63%. And gabapentin, topiramate, all were effective medications in reducing that incidence development of alcohol-associated liver disease. Again, going back to the uncertain benefit of acamprosate, in this particular population study, it was associated with a 3 times likelihood of developing alcohol-associated liver disease. Again, these medications also impact the incidence of hepatic decompensation. And what's more important, I think, here is that when you prescribe these medications year in and year, you actually decrease by 3% and 7% the incidence of ALD or hepatic decompensation. So when we don't prescribe these medications, we're doing a disservice to our patients on a year-by-year basis. I'm just going to go really quickly through this and really just tell you that naltrexone and gabapentin in this particular population study significantly reduced the development of advanced associated liver disease, the development of hepatic decompensation, and pharmacotherapy significantly reduces and delays the incidence of acute on chronic AALD and results in more days of compensated liver disease. In terms of best practices, this is how I approach this. Whenever I'm talking about moderate to severe alcohol use disorder, my first line agents are oral naltrexone, extended release naltrexone, especially if the patient is complaining or describing cravings or preoccupations. Again, I hope I highlighted to you that topiramate has just demonstrated emergent evidence where it should be considered a first line agent. In terms of second line agents, topiramate, again, saying it might be a first line agent with moderate AUD. Acamprosate only because of the FDA-approved medication, but I think I've highlighted the clinical benefits are uncertain. And then topiramate if there's a co-occurring cocaine use disorder. In terms of generalized anxiety or alcohol-induced anxiety, I'm looking at oral naltrexone, extended release naltrexone in combination with the anxiolytic properties of gabapentin. When we're talking about opioid use disorder, we're treating with buprenorphine, naloxone, suboxone, methadone. Again, first-line agent, topiramate, acamprosate. We're avoiding a gabapentin. And then when we're talking about the population that I've been highlighting over the last hour or so, AUD cirrhosis, my first-line agent is oral naltrexone, extended-release naltrexone, and gabapentin. And just want to talk about an approach that I use when we're talking about caring for patients with alcohol use disorder. It's an ADAPT model. I highlighted, hopefully during this talk, that we should be aware of the significant healthcare utilization costs, mortality, and morbidity attributed to alcohol use disorder, cirrhosis. Using a standardized tool to diagnose alcohol use disorder, its severity, and its remission. And then focusing on the patient's preference, whether it's abstinence versus reduced alcohol use. And then there needs to be an assessment. And this is where I'm talking about the biopsychosocial cultural assessment. Focus on trauma, co-current mental health disorders, social determinants of health, racial, ethnic disparities and equities. And then prevention. That's using medications, whether it's FDA-approved, off-label medications, psychotherapy. All of these have been shown to decrease the incident development of alcohol-associated liver disease. And then treatment. Providing trauma-informed, non-stigmatizing alcohol use disorder care using FDA-approved medications and pharmacotherapy. Just go through my summary briefly. AUD is the most prevalent substance use disorder in the United States. Again, I highlighted how only less than 1% receive evidence-based pharmacotherapy. Increased alcohol use is driving healthcare utilization. Pre-pandemic data has exploded since the pandemic.